Welcome, and thank you for joining us for today's webinar, Cross-Sector Collaboration, Making Partnerships Work for Your Community. My name is Kathleen Amos, and I'm the Assistant Director of Academic Practice Linkages at the Public Health Foundation. And on behalf of our team here, we're excited to be speaking with you. We recognize that now is an even busier and more challenging time than usual, and very much appreciate your taking the time to be with us today. So just as we get started here, we wanted to go over a few housekeeping items for the webinar. So on the slide, you can see an image of the attendee control panel, which you should also see on the right side of your computer screen. This control panel is your hub for interacting with the webinar. First, in the control panel, you should see an audio section. You have two options for accessing audio for this webinar: listening through your computer speakers or calling in on the phone. If you're using your computer speakers, please choose the computer audio option. If you're using your phone, please choose the phone call option and enter your audio PIN found in the audio panel. Please make sure to select the audio option you're using, and if you choose to listen over the phone, please also be sure to mute your computer speakers to reduce any echoing. Regardless of which option you choose, all webinar attendees are muted. The slides for today's presentation are available for download in the handout section of your control panel. Links included in the slides are not actually live during the webinar itself, but they are live in the handout. So if you do download a copy of the slides, those links will take you to those additional resources. A number of you have submitted questions in advance of the webinar, and we thank you for doing so. We've used those questions and have built several of them into the presentation as we prepared the content for today. Please also continue to submit your questions or comments throughout the webinar via the questions box in your control panel. And please feel free to send in your questions at any time, and we'll address as many as possible during the Q&A session towards the end of the webinar. If you have any difficulty with any of the technology we're using today, please also use the questions box to just send us a message and we can help troubleshoot. And finally, this webinar is being recorded and the archive will be available following the webinar. So to get started, I would first like to introduce our organization, the Public Health Foundation, or PHF. PHF is a national nonprofit organization based in Washington, D.C. that serves the public health and population health workforce. We strive to improve public health and population health practice to support healthier communities, and we do this by providing resources and tools, training, and technical assistance to health departments and other organizations engaged in public health and population health nationwide. Our work is focused on performance improvement and organizational development, and specifically in the areas of quality improvement, performance management, and workforce development. And over the past 7 years, we have had the pleasure of working on site with more than 500 health departments and other organizations across the country. We learn so much from every experience, and we're happy to be able to share some of that with you today. I also wanted to introduce our presenters for today's webinar and give you a quick overview of what we'll talk about over the next hour. So Ron Bialik is up first. He is the president of the Public Health Foundation, and he will be providing some background on cross-sector collaboration to help set the stage for our discussion. Jack Moran is our senior quality advisor and will share with you tools and tips for engaging in cross-sector collaboration, as well as some examples of cross-sector collaboration. I will then dive a little bit deeper into a particular type of cross-sector collaboration and take us to the Q&A portion of the webinar. And we're also joined by Vanessa Lammers, who's our Assistant Director of Performance Management and Quality Improvement. And she is helping to moderate the webinar and is also making sure that all of the technology functions smoothly. So with those introductions, I'd like to turn things over to Vanessa to take us through a quick poll to help us get to know a little bit about you as well, and specifically where you feel you are in your cross-sector collaboration journey. Vanessa?
Thanks, Kathleen. So I'm going to launch our poll. Asking you where you are in your cross-sector collaboration journey. Please vote on one of our 4 options here. Give everyone just one more minute. Oh, wow, great participation. Looks like over 70% have voted. So I'm just going to go ahead and close the poll. share the results with everyone. So by far our winner is learning about cross-sector benefits. And then a three-way tie for the others: identified cross-sector benefits, established cross-sector partnership, and expanding cross-sector partnership. And with that, we'll kick it over to Ron.
Thank you so much, Vanessa, and welcome to everybody joining us today. It was interesting looking at the poll results, and we believe that we will have something that will touch on topics for each of you. And those of you who've had the collaborations going for many years, please share your experiences with the chat box area. We'll capture those as well. Well, let's talk about the need for cross-sector collaboration. We know that in today's world and today's communities, there are many complex health issues, complex needs, and complex solutions. And really, none of these, institutional racism, social determinants of health, adverse childhood experiences, none of those can be solved through a single organization or a single sector working on it. It really does require cross-sector collaboration. And then if we look at some of the overarching social issues, social health issues of the day, like climate change and of course COVID-19, again, we see the need for cross-sector collaborations. And let's just focus for a moment on COVID-19. We have public health, we have healthcare, we have first responders, social services, transportation, community-based organizations, grocers, manufacturers, and many others working across sectors, collaborating to get the job done, to get it done quickly, to get it done effectively, to meet critical needs of our communities. And so we need to be thinking about what opportunities does this create for us in terms of longer-term cross-sector collaborations? What relationships have been formed as a result of COVID-19? What partnerships have been established? How can we build on those and continue to grow those over time? This is a quote from a 2014 Robert Wood Johnson Foundation commission to build a healthier America report. And there's nothing really new in this. We've known a lot of this for many years, that cross-sector work is critical for healthier communities. What's really happened, I think, over the past decade or so is that what's been highlighted is a new understanding of the needs to work across sectors, new circumstances, new science as well. And again, when we think about COVID-19, that has many horrors associated with it, but also opportunities for us to expand these cross-sector collaborations. As an organization, over about the past 7 years or so, we've been out and provided training and technical assistance to about 500 organizations. So what have we been seeing as far as cross-sector partnerships and cross-sector collaboration? We've really moved from about 10 years ago where people recognize that this is interesting, it's something I want to learn more about, but I don't really know how to do, to maybe about 5 years ago where organizations were beginning to think more and more about how to firm up their thinking in this area and begin these collaborations, to more recently where we've actually seen the collaborations taking hold. Many are short-lived, and Jack is going to address some of those issues about how do you move from the short-term successes to something that's longer-term and more sustainable over time. So cross-sector collaborations can certainly be difficult. They can certainly be frustrating. And frankly, the first time, it may not work. The second time, it may not work. But what's critical is to be thinking about, each dive may be just a little bit better than the last one. And what's really important is that ultimately the rewards to the community, to community health, can be enormous from effective, long-term cross-sector collaborations. So I'd like to take a moment and just talk about a cross-sector collaboration with regard to childhood lead poisoning. This is Philadelphia, housing in Philadelphia. And if we look back to 2002, there was a backlog of about 1,400 properties requiring remediation. Elevated blood lead levels were at about 12% for children tested. The Philadelphia Health Department at that point said, this is totally unacceptable. Began discussions internally with city agencies, housing, justice, social services, and others, and then began working with other sectors, lawyers, realtors, court system, contractors, and others. The city then established a lead court. The lead court resulted in more quickly and effectively addressing orders to remediate lead in properties. So what was the result? The backlog dramatically dropped, and in 2014, rather than 12% of children being tested having elevated blood lead levels, it was 1.7%. Tremendous impact on the health of children, the health of communities. Philadelphia would like to get that to zero and continues to work in these areas, but they have made enormous progress, long-term progress, a sustained cross-sector collaboration that has really helped the city, its children, and its residents. So finally, I'd like to talk about what can one do today? What can we do to create or enhance cross-sector partnerships? Well, if you think about community needs, if you think about them pre and during and post the COVID-19 pandemic, look around your community to see who's been engaged in the COVID-19 response. Some responses may be related to long-standing public health issues and needs like TB, STIs, childhood lead poisoning. Some may be directly related to COVID-19. And ask yourself, who shares your organization's vision and mission? Can you begin bringing these organizations to the table, or can you join their table to address some of the current and long-standing health issues? What about reinforcing and building a bigger COVID-19 table that can address other needs within the community? And if you have existing collaborations, can you work on further defining the priorities as we move forward? What's not being done during this time of the COVID-19 pandemic? What needs to be done? Can we go as far as setting objectives and timeframes? Can we begin addressing unsaid issues and raising those issues? And can you commit to and take action? So certainly face-to-face meetings are out of the question at the moment, but many of us have become more comfortable with video meetings and the imperfections of those meetings. And we've even learned how to reuse the telephone. So during this time of COVID-19, there's been more of a personal and human touch to the work that we do and acceptance of imperfections. And I don't know if you saw the recent, or this past weekend, Saturday Night Live episode where skits were broadcast from homes. There were lots of imperfections, but a clear desire to entertain and a personal and human touch throughout. So even during this time of the COVID-19 pandemic, you can indeed develop, expand, and enhance the work of cross-sector collaborations to improve your community's health. And with that, Jack, I would like to turn it over to you.
Well, thank you, Ron. Welcome, everybody. One of the things about doing cross-sectional collaboration is that over the last few years, I've had the opportunity to start up probably 30 of them across the country. And before that, I was president of the board of Maine CDC Choose to Be Healthy, Southern York County Collaborative for 6 years. So I've had some experience doing this. And these, what you'll see today, is the things I've learned the hard way. As it talks about here, is that really to get a collaborative going cross-sectionally is you got to get everybody to break out of their silos. Now, I know we've heard that many times, and it's a difficult thing. The other thing you need to do is get the right community partners on any issue that needs improvement. And the one that I've found always happens is that if you open the up to anybody, you need to do it by inviting, because if you open it up to anybody, what happens is you get my favorite people, the drop-ins. They come 10 to 15 minutes late, stay 15 minutes, see what the agenda is, get their name on the attendance sheet, and make sure their little piece of the turf is protected, and then they're gone. They never volunteer for anything. They never help out. So as you do this community partners, think about how do I get the right people. The other thing to think about, oops, I went too far. I don't know how to get back there. Let's see. Let me see if I can get back. Sorry about that. Whoops, I've gone way too far. One thing, people should never give me permission to do things. I'll just talk about this slide. These are the people you really want to get. And think about it as you start to who you want to get. One of the ones we talk on the top here is they have high influence in the community, but a lot of time they don't have a lot of interest in the health issue. And these are great change facilitators because on a cross-sectional collaboration, you need somebody that can facilitate it, somebody that can draw the people out, ask the tough questions, put the difficult decision on the table. And if you can get somebody that's like neutral like that, it's great to have somebody like that. The other ones you see towards the bottom on the left, the change resistors, they are the ones that come to protect their turf. They have grants, they have people, they want to make sure that they don't get resisted. And what they want to do is make sure that nobody tries to take any of it. The change enabler is a great person too, because they're the worker bees in the group. They know the system, they know the people, they can move things through it. You need somebody in housing, they know who to get. You need somebody at the, the playground area, they know who to get. And then the change agent's really the one that's going to lead it as you go forward. And these are the people that can really push it forward. And the change agents are really key people. They have key skills that we need as we go forward. And initial step really is to conduct a readiness assessment. And really what the group is you want to do is to try to figure out where is everybody? What are the things we have in common? What are our differences? What are the barriers? And then what is it going to take us to do this collaboration successfully? And when we get the barriers and the differences, we need to make sure we resolve them before moving forward. Because if we don't, what happens is they come up later on and derail the project. Now, commonalities in this case, when we start with that, this is really where we focus on improving the community health. We have similar customers, we have similar patients, we have similar community members. And do we really understand the need, and do we have the desire as a group to do this? It's a key thing when you start this off to talk with everybody in the group that you've invited, that they will come along and make sure that this is really what they want to do in this case. And commonalities, can be a long list, but as you go through it, you find out people have a lot in common. And then the next step is to look at the differences. As we look at the different people and participants in the group and different organizations they represent, what are their workforce skills? A key thing I have found all the time is vocabulary. You call it X, I call it Y, it means the same thing. So a good thing to do is put up a sheet of flip chart paper as you go along, capture key vocabulary items, and make an identification of it so that we have it in the future, so we don't keep stumbling over it every time. We have different funding sources, and different funding sources, different grants may have different requirements. And then we offer different services, probably to the same people that we're all trying to improve in this case. So there's a lot of differences that we see as a group. And then barriers. Well, the old one, silos, they're always there. The people want to stay in their lane. They don't want to move it out because of their funding sources. They don't have the staff to engage others. There's workforce gaps. There's sharing of information. We don't want to do that. And we don't want to share resources is a key thing. Now, the collaboration areas, we can have aligned priorities. It's good to focus on the social determinants of health. Willing to leverage resources is a key thing. Will we do that? Will we leverage resources? Will we combine them? Will we give up a little bit of this to get a little bit of that? And it's a key thing with people is that a lot of times people don't want to give up anything. And then will we engage in the cross-sector initiative? Now, to make this work, I found these are the key questions that you have to answer. And as we go through it, you know, will we collaborate, cooperate, and coordinate resources for the collective good for the community? Now, when you do this question, most everybody will say yes, but what they really mean is maybe. What's in it for me? So that's always in the background. Can we agree on a common health improvement for the aim for the community? Most everybody will do that. Why would I be there if I wasn't agreeing with this? Can we work collaboratively? Hopefully. Are we willing to pool and leverage our partners' assets? Again, this is where some people will say yes, but remember, it's always a maybe. It's maybe. Maybe I will, maybe I won't. But it's one of those key ones you need to get an answer to. Consolidate programs and services to make them more efficient, effective, and available to achieve the community health improvement aim. This is a very difficult one. Will people work together? If we have a program, an organization X, Y, and Z that are similar, would we be willing to pull them together and do it one program rather than 3 different ones? Again, a very difficult question. Are we willing to allow community residents on our collaborative task force? Well, a lot of times that's a stumbling block. Some will do it, some won't. It's a good idea if you do because they bring a perspective of what they need, what they want, and how they're receiving it now, and what will help them do it better. And then are we willing to allow community residents to shape the voice for the health of their community? Again, it's a very good one to do, but again, will the collaborative do it? And it's a key part of the process as you go forward. Now, the other thing was, there was a question somebody had sent in. How do we measure the coalition and its functioning as effective partnership? Well, we've developed this tool. It says 20 questions. Just showed a few of them here, and it has an Excel spreadsheet attached to it. But what we do as the coalition as we go along is we give this out every once in a while, maybe every month, maybe every quarter. It depends on how often you meet, and really ask the group to rate themselves from strongly disagree to strongly agree. And hopefully what you see over time is we get more strongly agrees and agrees than we start off with a lot of disagrees, strongly disagree. But it's a way to measure the coalition. And then you can find the ones where there are some difficulties, disagree and strongly disagree, and work with the group to really assess how they can overcome that and move it forward. So assessment as you go along is a key part of sustainability, because as you move forward, you want to get the group into action. And once you get into action, you want to make sure that everybody's in agreement and that we have clear purpose in front of us. Now, one of the tools we use to keep the group engaged is that we use a thing called a driver diagram, population health driver diagram. And what it really represents is the team members thinking on cause and effect in the system and what projects will really help us to move our aim forward and achieve the goals that we want to do in this system. And it really keeps help identifying what aspects of the change we should measure and monitor as we move forward. And when you look at a driver diagram, it looks rather complicated. It takes about 4 meetings to get this done. The first meeting, we usually work with the anchor organization and a few key selected people. So we try to keep the group small, somewhere between 6 to 8. And the idea in this case is to develop what is the goal, what's the aim we want to achieve, and then what are the various goals that we think this group can achieve. Then we develop a set of primary drivers. These are the things that will drive it forward, and things that we can leverage. So the first couple of things we do defines the desired change. The next couple of things, the primary and secondary drivers, tell us where the leverage is in the system. And the secondary drivers, we sort of scope those out and we develop a draft. And then what we do is we bring this draft to another group, a little larger group, and sort of have them review it. So we're really only going from the aim, goals, primary drivers, secondary drivers, and flush it out. And then we bring it to the large group. This is where we might have a coalition. We've done this as large as 70 people, down as low as 20 people. And what happens is we do this thing called add, change, delete matrix. And we go through a rotation. So everybody broken up, say we have 60 people, we break it up into 3 groups around the 3 primary drivers. And we rotate it every 20 minutes. And we have a team leader for each of the primary drivers. And they record what the people in each of the groups think. Should we add to this? Should we delete it? Should we accept it as it is? And then when we finish that rotation, an hour or so, we have a cleaned up version so that everybody can then begin to see where are the focus points of primary drivers. And then what you can do in this case, either at that meeting or the next meeting, is you can break up into teams. Who wants to be on the primary driver 1, 2, 3, and then have the group start to think about how would they develop projects, community change concepts that would begin to implement the secondary drivers and achieve the primary drivers. And the groups would work maybe for a couple of months on change concepts, try some trial solutions. Key part of what we do is we develop metrics. So we measure it to tell if we are achieving what we're doing. And then we can come up with a trial in this case and see if it works. If it doesn't, we can go back and improve it. And then we can do a wide-scale implementation once we understand what the key components are that will make this specifically work. And when we finish this, when you have it done, you have a nice change package that you can continue to review. So the first pass through this with most of the groups I'm working with goes anywhere from 6 to 8 months. And what we found around sustainability is, the good thing is, maybe at that point, you might want to change the anchor organization. Where is it going when you have a review? You might go back and review the primary drivers, secondary drivers, maybe new things need to be added. Maybe another group needs to take over at that point. As you find after a year of doing this, you've got some solutions. That's great. You've implemented them. You have results. Now it's time to move to the next phase. So to keep it sustained, you need to have some change in the system. Maybe you need to change the participants. Maybe you need to change the anchor organization. Maybe you need to change the leader. But it's a chance then to review it. And that helps with the sustainability. Another thing we tell the groups to do is use the thing we call the ripple effect diagram. Something we developed back for FIT last year. And this is an example we have is what's the ripple when we do something in the community, like we improve something, we put in a farmer's market, let's say, what's the ripple through the community once that happens? And begin to look at it and map it out, because you're going to find in this case, not just the results you got by implementing the farmer's market, but what happened beyond that. What was the good things that happened? And that's a very needed thing to happen with the group, because then they can see how did the change sustain itself going forward. And some of the things that we have worked on, these are some of the ones we worked on: diabetes programs, we worked on healthy eating, neonatal abstinence syndrome, we worked on vector control around mosquitoes, water quality, well child visit. The first one we did, and this is on our website for you to look at, is called antibiotic stewardship. And this was a key one we worked on to develop a program that public health hospitals could work together and really reduce the use of antibiotics in their community. So these are some of the ones we've done. And we found, with the success over time is that it really takes a very good anchor organization to head it up, and it takes committed people to make it happen. And then what you really have to work on all the way through is measuring yourself to see how well you're doing, head off problems right away from the measurement system that we talked about with that 20 questions, and work with the group to reduce those types of barriers that come across, and then think about a sustainability program for the organization going forward. And sometimes it means changing leaderships and so forth, because as you move forward on that particular issue, the scope may change as you implement things and are very successful. So I will turn it over to Kathleen now.
Great, thank you, Jack. So as Jack has just mentioned, we've worked in a number of areas on cross-sector collaboration, hit on a number of different topics. And I'd also like to spend the next few minutes just digging a little bit deeper into one specific type of more formal collaboration, of what is known as an academic health department partnership. So this type of partnership is one that exists between a health department or other type of public health practice organization and an academic institution. So it creates a bridge between the academic and practice worlds, if you will, or a connection that ties those two or more organizations together. So this partnership helps to institutionalize, for lack of a better word, the kinds of collaboration that we've been discussing, and really to help move the relationship between the organizations beyond working together sporadically because, you know, two individuals happen to like each other or whatnot, to make it more a regular part of how the organizations do business. And these types of relationships, these partnerships can really help to enhance public health education and training, research and service delivery. See if I can move the slide. Perfect. So as with any type of collaboration, as you might imagine, there is a whole lot of variety in terms of what an academic health department or AHD partnership looks like, who is involved, how they're structured, that kind of stuff. And there really is no one right way to develop a partnership, but there are some common characteristics that are often present in these types of relationships and that we often talk about as defining an academic health department partnership. So at the most basic level, an AHD partnership has at least one academic institution and one public health practice organization, this is typically a health department, working together. And then building on that, there are a number of additional elements that may be present. So you might see some type of written agreement that links the organizations together. This could be a contract, memorandum of agreement, a memorandum of understanding, you know, that kind of thing. And through the partnership, the organizations may engage collaboratively in providing education and training to both students as well as the current workforce, work together on joint research projects, or jointly provide public health services. And these partnerships may also include the sharing of personnel, funding, or other types of resources between the organizations. And the success of all of this, you know, as Jack has just been emphasizing, is really dependent on having communication and mutual trust between the people involved, and an understanding of where other people are coming from. So even if what constitutes an AHD partnership varies from one place to the next, we do know that these partnerships, or partnerships in general between academic and practice organizations, are very common. And we know this because both the Association of State and Territorial Health Officials and the National Association of County and City Health Officials collect data through their profile studies about health department partnerships. And these data show that the majority of state and local health departments work with academic institutions in some way. So the most recent data shows 100% of state health departments working on projects with academic institutions, and conversely, 0% reporting that they have no relationship in place. And then for local health departments, about 86% of local health departments work with colleges or universities in some way, with about 45% having regular meetings, written agreements, or sharing personnel or resources. So some of the things that we tend to associate with having a more formal partnership. And this map is a little bit old at the moment, so there are more partnerships even than what you see here, but just wanted to illustrate that these partnerships really do exist across the country, and they also involve a variety of partners. So as I mentioned, we do tend to see the practice partner in an academic health department partnership being a health department, and these health departments may partner with an array of academic partners, including, for example, schools or programs of public health, medicine, nursing, pharmacy, nutrition, public affairs, journalism, engineering. You know, as we have more and more recognition of and emphasis placed on the social determinants of health and the variety of disciplines that impact health in some way, the sky really is the limit in terms of the partners who could contribute to achieving health goals. Academic partners may also represent different types of institutions. So for example, in the Rhode Island Department of Health is building partnerships with academic institutions across the state, ranging from the School of Public Health at Brown University to Providence College to the Community College of Rhode Island and the New England Institute of Technology. So really an array of schools, all of which will have different focus areas. And these partnerships may also bring in other relevant partners such as hospitals or medical centers and really move beyond sort of a one-to-one partnership to having more of a group working together. For example, in Worcester, Massachusetts, they've set up an academic health collaborative that encompasses the local health department, several local universities, as well as the UMass Memorial Medical Center. And these partnerships do also exist at various levels within public health as well. So you see these partnerships operating or being built at a statewide level, for example, in Massachusetts and New York, in large cities and counties like New York City, Chicago, Jefferson County, Alabama, Maricopa County, Arizona, as well as in rural areas such as Boone County, Illinois, and Granville and Vance counties in North Carolina. So really, these types of partnerships are present in all types of environments. And obviously, engaging in any kind of collaboration really does require time and resources. So there do need to be benefits for all of the organizations involved that make putting in that time and effort worth it. Speaking in terms of AHD partnerships, there are a number of reasons for why organizations might participate in such partnerships. These partnerships can help the organizations better prepare students for careers in public health practice, recruit qualified academic and practice personnel, so both graduating students as well as professionals who are already in the workforce, facilitate lifelong learning for both practitioners and faculty, develop and use research that is relevant to practice, increase awareness of public health and what it does, and maximize the use of limited resources, as well as essentially enhancing the organization's competitiveness for new resources, and meeting the standards of accreditation for both health departments and academic institutions through the Public Health Accreditation Board and the Council on Education for Public Health. And then I really wanted to just focus for a minute on the last two bullets that you see on the slide here, as I think they're particularly timely and tie into what Ron was talking about earlier in relation to the response to COVID-19. So AHD partnerships can really help organizations better address community health needs and emerging health issues and increase the organization's capacity to both strengthen the public health system and protect and improve community health. And this is the idea, of course, that, you know, we're stronger when we all work together than when each organization is operating individually and going it alone. And each organization has kind of a piece of the puzzle and has some resources that can be used for meeting community health needs, and we can really maximize the impact that we can have by aligning with others in a common purpose. And I think this is really being well highlighted lately by some of the ways that health departments and academic institutions are partnering and working together to support the response to COVID-19. And this can be both drawing on existing partnerships that are longstanding and have been in place for many years, as well as reaching out to new partners and really getting those partnerships started. So just a couple of examples. In Florida, the Department of Health really had a need for epidemiologists to increase that capacity, and they connected with 5 universities in the state. And in one weekend, they were able to recruit 100 professors and students to work with their state epidemiologists to do contact tracing and really help the state try to figure out how the disease was spreading through the communities. In Massachusetts, they have an academic health consortium that they've had for a while, which involves the state health department as well as 11 local schools and programs of public health. And through that consortium, they've activated more than 1,600 public health students in the last little bit to support the response. And the consortium has helped place hundreds of students with more than 40 local boards of health around the state to support case tracing, social media, communication efforts, as well as administrative tasks related to addressing COVID-19. And finally, a third slightly different example is with the Toledo-Lucas County Health Department in Ohio, which by the end of March had they had six, I believe, employees within their health department who tested positive for coronavirus. And so then, in addition to those employees being out, having to isolate employees who've been in close contact with them, and that left some gaps in management positions that were really key to their plans for response. And so, in putting together a backup plan, the health department contacted other organizations for help, including the University of Toledo that they work with, which sent graduate students from its public health programs to help provide support. So really, I think that all of these examples illustrate really well how partnerships can help expand your capacity and how key they can be to addressing critical health needs within your community. So to support individuals and organizations in developing and sustaining such partnerships, the Academic Health Department Learning Community was set up by the Council on Linkages between Academia and Public Health Practice in 2011. And this community brings together practitioners, educators, researchers, and others from across the country to explore AHD partnerships, share their experiences, and engage in collaborative learning. So the community currently has more than 1,200 members and offers a way for people to connect with others who are engaged in this work, as well as tools, resources, training, and technical assistance to organizations working to establish and grow their partnerships. Learning community activities more specifically include the sharing of stories and examples of academic health department partnerships, webinars featuring those partnerships. We have examples of agreements that are used for formalizing partnerships, a listserv for engaging in community dialogue, and we do offer technical assistance to answer members and others' questions. Membership in this community and all of the resources that the community creates are all freely available to anyone who would like to use them. And so if you are interested in joining or learning more about it, please feel free to just send me an email. I'll put my email address on the slide there and let me know. I'm happy to connect you. And so with that, I know we've saved about 15 minutes or so for questions. We would really like to hear from you and open the floor for your questions. I know we received a number of questions in advance as well as already in the chat box, but please do continue to send your questions and comments into the chat box. We'll address as many as we can. And I imagine that we are not going to be able to address all the questions live today, but for any that we do not get a chance to answer now, we'll follow up with answers after the webinar. And just to reiterate and address, I know we've had a few questions related to slides and recording. We are recording the webinar and we will be sharing the archive as well as the slides with you after the event. So thank you. I'll turn it over to Vanessa now to see what questions that have come in.
Thanks, Kathleen, and thanks everybody for a wonderful presentation. We do have quite a few questions, and we did receive questions prior to the webinar through the registration. So let's start off with how can cross-collaboration and shared resources help overcome obstacles in funding? Should partners pair up on grants?
I'm happy to jump in on this one if you like. So I think in terms of, we had a lot of questions about funding related to academic health departments and, how do you sort of build a collaboration if you don't have funding specifically to do it. And I do think that there are a lot of ways to take advantage of the resources that you do have, whether it's actual dollars or, in-kind resources, and sort of maximize what you do have already. I also think we've seen several examples where, and I kind of alluded to this a little bit, where having partnerships has made organizations more attractive to funders, so that organizations have shared that they feel more competitive for resources when they have that kind of larger partnership expertise network to draw on. So a couple of examples off the top of my head. In North Carolina, there's a rural local health department in North Carolina, and they were able to, they set up a partnership with the University of North Carolina, and were able to jointly apply for some grant funding related to some work they wanted to do in nutrition. And they've been successful over the last year or so, I don't know, little while, in getting more than $3 million in new grant funding for their organization. And given the size of the health department and the budget, that's made a really big impact from them. Also, there's a partnership in Virginia with Virginia Tech University, where they're working with the local health department in their area to really provide some of the evaluation capacity for the health department on grants that the health department is writing. And they feel like that has made them more successful because they do have that additional expertise that they can draw on in-house. So yeah, I hope that helps a little bit. I know the funding is always a tough question.
Absolutely. Lots more questions. So here's another one. How would you keep partners motivated and involved if no funding exists to carry out their proposed goals and projects?
Awesome. I'm happy to keep talking, I guess. This is another area that I feel like we talk a lot about. And so a lot of the motivation, I think, at least in the work that I do with the academic health department partnership, comes from needing to accomplish something. And every organization has things that they need to accomplish, or individuals have things that they need to accomplish that would be easier to do if they had other resources or other people to draw on. So I think finding those areas where having a partner either allows you to accomplish something that you wouldn't have been able to otherwise, or be able to do something more effectively than you would be able to otherwise. And those motivations are likely different for different partners. So we often see, from the academic side, academic institutions need to provide practicum placements for their public health students in order for those students to complete their degrees. And so having a partnership with a health department allows them potentially to access to provide those experiences for students. We've talked with a number of health departments who have talked about how having partnership in place has really helped them in pursuing accreditation, either because they didn't have enough capacity within their health department to tackle all of the pieces of accreditation at once. It's helped them do it more quickly, provided assistance with health assessments, data analysis, that kind of stuff. So I do think if you can find the areas, the things that people need to do that they can't really do by themselves, or would be easier or faster, or what have you, to do if they had more someone to work with on it, those can be good motivating factors. I don't know if anyone else has any other thoughts on that.
Yeah, Vanessa, Kathleen, I do. This is Jack. One of the things we do when we do the driver diagram is when we have the primary drivers, we ask everybody to do an exercise called "What's in My Backyard?" And the purpose of the exercise is each of the participants in the cross-sector collaboration gets up and talks about what resources they have and what they do. And it's always amazing how many people don't know what the other people are doing. So sometimes we're able to draw in some of those resources when we don't have any funding. But as you get down on the driver diagram with bigger projects, you will find that you do need funding. And one thing that's worked effectively, and a couple of the collaboratives I've done, is that they have invited a local foundation to become part of the collaborative. So up front, this foundation is interested in this particular topic. They are there to see, is the project coming down? Can you fund any of them? And then the other part is to go looking for grants. But what that has done in the past is it's slowed it down because you might have to wait 3-6 months to get a grant. So we have the groups think ahead of time as they're going along. Will we need funding for this particular project? And let's get started early on looking for funds.
Excellent. Thanks, Jack. Another common theme of a question is, how can we assure accountability?
Well, the key thing we do there is that it's measurement. And measurement is a key part of the whole process with the driver diagram, in that we have a whole column for metrics. So once we have projects, we want to go back and see what are the indicators that tell us that these projects are working, and are they accomplishing the goals. Too often, I've seen in the past, the coalitions get going and they don't measure what they did. They don't know where they're starting from, so we develop baselines of any project starting off. What's the impact right now? How much do we want to improve it? Over how much time? And then the key goal is, did we improve it? So we always have that measurement process going on in the background.
Yeah, I think that makes a lot of sense. And we also see with a lot of the academic health department relationships, they're often formalized by some kind of contract or memorandum of understanding. And so that does make it a little bit, puts a little bit more of that structure in place as well, where they've gone through and discussed early on who's responsible for what, how things, the roles and responsibilities and all those pieces, and potentially laid out even a work plan for what they want to do over the next year or 2 years or what have you. And so that, I think, helps to add to some of that accountability as well.
Yes, excellent point. And we also have in the questions box a lot of familiar people finding a lot of solidarity and familiarity with everything that you are both talking about today. So another question is, another common theme, a couple of people have asked this in different ways, but recommendations on ways to re-engage community partners after changes of leadership or potential unresponsiveness.
Well, I can take that one. One of the ones we've had a lot of times is collaborations is that, maybe the key leader of the backbone organization leaves suddenly. We've had a couple where people, went on to another job just as things got rolling. But the thing to do is have backups. One of the things I found is that as you go along, we have primary team leaders, have a secondary one behind them. So if something happens, they're able to take it on and move it forward. And again, when you see the key leadership leave, it's a good time to really go back and, assess the organization, as we showed in that 20 questions we have. Where are people feeling at this point? The other thing to do is go back and look at the readiness matrix we talked about and see, is that person left? Are there more barriers, are there more differences, or do we have more commonalities or more collaboration areas? Sometimes if you have a key person leave, it might be for the good. You never know. And so think about it as you go forward, is always keeping that idea of re-engagement. Re-engagement is one where we find new blood comes into the organization. That's why after about 8 months of working with a driver diagram, a lot of projects have been accomplished. We sit down and look at the driver diagram again and say, what goals have we accomplished? Do we have new goals we want to do? Are there new projects to work on? Do we need new people? And that's a key part of this whole thing, is the sustainability is bringing in new blood as you go along.
Great. Thanks, Jack. That's really helpful. Maybe one or two more questions. Many questions about the backbone or the anchor organizations. How can this work effectively if there is more than one backbone organization?
Well, ones I've done, we've had a few, we have 2 backbone organizations. And what happens is when you have the meeting, it's very difficult sometimes because they come different directions. So what we've done is put together a small steering committee. Each one of the backbone organizations has identified one key person who can coordinate the resources from each of their organizations. So it might be where you hold a meeting in their organization. It might be things like getting the minutes out. What we've done is delineated clear responsibilities for each of the organizations. And it's really a negotiation process. As we all know, everybody likes to be the one that gets the credit. But in a collaborative, it's really shared credit, and that's sometimes difficult for people to do. And what you really do is delineate clearly what are the responsibilities of each of the organizations, what are they each going to do, and make it very clear to the participants in the collaborative at that point, this is what they're going to each do, and this is what they bring to the process to help it move it forward. So communications is a key thing in clear delineation of responsibilities.
Excellent. Several similar questions along those lines. And someone also asked, what is the best way to go about selecting an anchor or convening organization to manage the process? Are there certain qualities?
Well, one of the things we usually look for is it a topic, the cross collaboration, is it a community issue they're really interested in? Is it something they have championed in the past? Is it something that they want to do and move it forward? And a key part of that is we usually look internally with the organization and see what kind of resources they are currently devoting to that. And is it something that they really can make an impact in the community? The other thing about the anchor organization is you want to have one that isn't the, I'm trying to think which one I call this, the big cheese in the community. You know, they always lead everything. And people look at them as, you know, pushing things forward. A lot of times I found when we picked one where they are the big cheese in the community, other people don't step up to the plate because they figure they're going to do it. So you want to get an anchor organization that has credibility in the community, is one that's seen that has a desire to make this happen, and one that's really willing to put their resources to it, you know, in the short term. And I usually talk short term is for a year, because an anchor organization runs it for a year, you'll find they tire. And you need to get a new anchor organization because the project may have changed by then because you've accomplished things. And now you're looking at a slightly different view of the original community health improvement. It may take on a different thing. It might be you started off dealing with access to healthcare, and now it's more about transportation. And another anchor organization would be better off dealing with that.
Thanks, Jack. And thank you to all our presenters. I think that's all the questions that we have for today. So I'm going to turn it back over to Kathleen to close us out.
Thank you. So yeah, we wanted to be conscious of everyone's time. I realize we're at the top of the hour, but we did want to close with just a handful of resources that may be useful as you continue on your cross-sector collaboration journey. So you can find out more about the two tools that we discussed today, the Readiness Matrix for cross-sector collaboration, as well as a population health driver diagram on our website. And we also offer customized technical assistance to help your organization and community form, enhance, and sustain successful cross-sector collaboratives. As well as we have a book featuring more than 50 population health experts providing insights in how to address population health issues and challenges in a collaborative way. I also put the link to the Academic Health Department Learning Community on this slide, so you can access that online. And if you are interested in learning more and staying up to date as new tools and resources are released or events are scheduled, we invite you to subscribe to our monthly PHS e-news for the latest updates. And finally, if you have additional questions or would like to explore any of this further, please feel free to reach out to us and we'd be happy to discuss. So with that, we'd like to thank you once again for joining us for the webinar. We did record it, so we will share the archive, the slides, as well as the answers to all of the questions that were asked today. So we'll share those all with you as soon as we can pull them all together. It has been a pleasure talking with you. We really do hope you enjoyed the webinar and enjoy the rest of your day. Thank you.